get started. Welcome everybody. I see some familiar faces and some new faces, which is great. So this is our today's Lunch and Learn. If you haven't noticed, in honor of National Social Work Month, we have cookies and coffee, so help yourselves. So my name's Mary LeClue. For those of you who don't know me, I'm the director of the MSW program at WVU, and today we have with us Kristen, Boyce, and Matthew Bunner. So I'm going to have them tell you a little bit about themselves in a minute, but they are going to talk today about family-based treatment for eating disorders, which is a really exciting topic. Couple of business things. I have a sign-in sheet I'm going to pass around. I'm going to ask you all to just make sure you sign in. I also have evaluation forms that I'm going to ask you to fill out and return on your way out today. If you're a provider and you are interested in continuing education credits, just come up on your way out and get a certificate before you leave. And I think that's it. We like to keep these pretty informal, so if you have questions or want to jump in, feel free. But I'm going to pass these around, and then in about 2 minutes, I'm going to turn it over to our speakers for today. So I'm going to turn it over to you guys and let you tell us a little bit about yourselves and what you're going to talk to us about today.
Well, thank you guys for coming. The weather was very interesting this morning and last night, so thank you. We appreciate your attendance. So I'm Kristen Boyce. I'm a clinical therapist at Chestnut Ridge, and I work mainly with children and adolescents as well as their families.
I'm Matthew Bunner. I also work in the child and adolescent section. I'm a licensed professional counselor, and I also work mostly with adolescents and their families, especially with eating disorders.
So today we're going to talk about family-based treatments for eating disorders, specifically with the adolescent population.
And it's going to be focused primarily on anorexia nervosa and bulimia nervosa. There's some other eating disorders that family-based treatment can be used for, but those are the two that we're going to be talking about.
So first thing, so this is DSM criteria for anorexia nervosa. So it's persistent restriction of energy intake that leads to low body weight. That usually there's an intense fear of gaining weight or becoming fat, as well as a disturbance in the way one's body weight or shape is experienced within their body. There's subtypes, so there's restricting type and binge eating and purging type.
So bulimia nervosa is a little bit different. It kind of has these recurrent episodes of binge eating followed by purging behavior. So the binge eating is where they eat a large amount of food within about 2 hours. And they have this sense of loss of control, and they just feel like they can't stop. Following that, there's these compensatory behaviors, such as, we call them purging, but that's like vomiting, misuse of laxatives, diuretics, or fasting, creating like this food debt, like, oh, I've eaten this, so like I can't eat for this long, and then also over-exercising. These binges and purging behaviors need to be once a week for at least 3 months. There's also this self-evaluation process that goes into it, where it unduly kind of influences their evaluation of themselves. So like, oh, you know, because I'm heavier, I mean less to the world. And this disturbance does not occur exclusively within anorexia. Some of these other eating disorders in the DSM-5 is binge eating disorder, like rumination disorder, avoidant restrictive food intake disorder, and that's the one with most of the research coming out about adaptations for family-based treatment, and then other specified eating or feeding disorders. So those are like sub-threshold, where they fit in many different categories.
What's a rumination disorder?
So it's where kiddos eat, and then they regurgitate the food, or they chew it and then they spit it out. So there's some screening tools that we use. The first one's SCOFF, and we'll talk more about that on the next slide. The eating disorder examination kind of gives us an idea about how severe the symptoms are. So that asks a lot about, you know, how often is this happening? How distressing is this for you? And what really happens within the eating disorder. The case stats and the kits are some structured interviews. Those you have to pay for, so we don't use those. We use just our clinical interviews. So the scoff, really good. You ask the question, you know, have you ever made yourself sick, thrown up because you felt uncomfortably full? Do you worry you've lost control over how much you've eaten? And have you recently lost more than 1 stone or 14 pounds, because this was done in the UK, in a 3-month period? Do you think you're too fat, even though others say you were too thin? Do you think food dominates your life? So 2 points on this really indicates that they should probably get some more attention.
So this is a lifetime prevalence study. So this was done in 2001 through 2004. So it's not completely accurate currently, but it does show that there's significance in lifetime prevalence. So obviously females, there's nearly double than males. However, it is common in both genders. And then even age ranges from 13 to 18 stays fairly consistent with the prevalence with age. And with this data, we also know that if early treatment is not provided within the first 3 years of symptoms, it's typically much more difficult to decrease those symptoms later in life. It's long lasting. So with that, anorexia is the 3rd most common chronic disease among young people. Between the ages of 15 and 24 with anorexia, they have a 10 times the risk of dying compared to the same age peers, and that's due to cardiovascular problems as well as suicide. And males represent 25% of individuals with anorexia, and they have a higher risk of dying as well, and that's due to later term diagnosis of the illness.
So these eating disorders, they impact every body system, especially the cardiovascular system. And that's something we'll talk about here in a couple minutes, but also the gastrointestinal system. Like if you think about restricting your food intake or regurgitating something, it's going to play a role. Your hormones, the endocrine system, skeletal, so think about osteoporosis, dermatologic, so our skin and hair in males, dull hair, brittle nails, dry, yellow skin, things like that. Oral and dental, so tooth decay and also like removing the calcium from our teeth. Psychological, neurological, and emotional. People get really rigid and obsessive as they start dropping in weight. So some signs to look for: appearance or physical changes. So obviously like changes in weight, but this can be concealed through like baggy clothing. A lot of kiddos who drop weight pretty rapidly will hide in oversized hoodies, things like that, just to keep it concealed. Kiddos who binge will often have clothes that are too tight, just because they try and purge and get rid of the calories, but purging is only about 40% effective, so they can't get rid of all of the kind of additional things that they're bringing in. In terms of academics, a lot of times you'll see a drop in grades, difficulty in focusing, just because so much of their time and energy is spent focusing on food, calories, weight, shape, those types of thought processes. And lack of participation. So you'll see that all across the board, whether that's perfectionism and not wanting to get that grade, or pulling out of gym class because they don't want to see like, oh, my body, my flesh jiggles, or I don't want to be judged. So they'll just kind of pull back. Behavioral changes in eating patterns. So restricting foods, cutting out food groups, or shrinking the portion sizes, completely avoiding meals in general. Driven exercise or fidgeting. So this might be the people who work out 3 times a day or for 2 or 3 hours at a time. Or you'll see them in your office or in the cafeteria, and they're like just be like bouncing, or they'll fidget with their hair or mess with their clothes, and those types of things. These kiddos often avoid the cafeteria or restaurants. So there'll be these big meltdowns. They get so anxious about people seeing them eat, and they can't conceal their behaviors that way. So then they have to like face what they're afraid of. Frequent trips to the bathroom. So this might be due to frequent purging, going immediately after meals, or they might be doing covert exercises. So I've had kids that are doing like squats and lunges in the shower, or hovering above the toilet seat, or doing push-ups, or any of those things, just because it's private and their parents really can't see it. And that can happen at school too. Some emotional pieces is their mood might be labile. It might just fluctuate the drop of a hat. Okay? They may also appear very depressed or flat. Okay? And isolation, the social piece, just because of so much of their thinking process is tied up in this, they'll start to pull back. This also may be secondary to being bullied, whether that's real or perceived. And so that they may also change groups quite frequently, just hopping from one to another. So some brief history. This was originally termed the Maudsley method, and it was developed in the 1980s in Maudsley Hospital in London. It continues to be refined in universities in Chicago, London, Melbourne, Mount Sinai in New York, Stanford, Sydney, and other centers around the world. And it takes key strategies from a variety of schools of family therapy, so structural family therapy at the Milan School, strategic family therapy, and narrative therapy. When we're talking about the framework, we as the therapist, the provider, has to take this agnostic view of illness. As research is kind of pointing in certain directions, but we really don't know what starts any specific illness, right? So it might be genetics, it might be their social situation, it might be their own psychology. It's probably all of them combined, but we can't say for certain. Parents will push you to be like, what caused this? And we really have to be like, well, we think these things might be at play, but we don't really know, and that's not what's important. What's important is being here and now and dealing with these symptoms. We take this non-authoritarian stance, so we can't really say you have to do this, especially to the parents, right? We do put it back on the parents and the family. You're in charge, you make these decisions. We act as consultants, and we're like, oh, this might work, this has been helpful for other parents, or oh, this is probably something that is a little slippery slope for you. But really, ultimately, they get to decide what's best for their family. We really focus on externalization and separation of the illness from the child, much like what we do in OCD. And then we keep the focus on symptoms initially.
So what is family-based treatment? So family-based treatment consists of 3 phases. Phase 1 is the start of all of the phases, and it's on a weekly basis. So at this point, we're charging parents with refeeding. Phase 2, we have moved to a bi-weekly basis, and parents start transitioning that control back to the adolescent. Phase 3, a monthly basis, and we're focusing on adolescent issues, their interest in their development at this point. Sessions go from 15 to 20 sessions. It can definitely be more if needed, and last roughly 6 months to a year with expert providers. It takes the treatment team approach, so there's a therapist involved, a pediatrician, and a psychiatrist, and we're constantly keeping in connection with each other throughout treatment.
And our team actually has a nutritionist, so we work with adolescent medicine very closely, and they kind of package their teams or their appointments as a one-stop shop kind of piece. So the family only has to pay one copay. They get to see the nutritionist, they see the resident or the faculty member, and that's been really helpful for us to utilize.
So who is appropriate for family-based treatment? So those individuals who are medically stable. It is designed to restore weight and decrease binging and purging episodes. Anyone who has had a brief hospitalization, so they're coming out and needing the follow-up services, so they've been determined medically stable. And then those families that have agreed to treatment.
So if a family says, we can't do this or we don't want to do this, then it would be counterproductive to even start this treatment. So in terms of medically stable, we want to think about orthostasis or the orthostatic blood pressure. And we check this at every visit in our clinic because we have MAs available, we have psychiatrists who can kind of back us up and say, oh, you're decompensating, you need to go to the hospital. So we check this by taking their blood pressure and their pulse in 3 positions. So we have them lay down, then we have them sit, and then we have them stand. And we look for a change in how their body's responding to those postural changes. So if the systolic and diastolic blood pressures change by more than 10, and their pulse increases by more than 35, then they meet criteria to go to the hospital because their body can't sustain it. And this is what we mean by those cardiovascular events. So because their electrolytes are often imbalanced, their heart can stop. So we want to get the medical attention. Hypothermia, bradycardia, tachycardia, and then, what's the other one? Kristen, help me out.
Hypo and hyper.
Yeah, hypo and hypertension. Those are all pieces that we would want to look for. So hypothermia is another one. These kiddos will complain about being cold a lot. So a temperature below 96 degrees is hypothermic. So they can meet criteria to go in inpatient.
So again, those people who are appropriate, medically stable, with the desire to restore weight and decrease binge eating and purging episodes. Anyone who has had a brief hospitalization, and families that agree to treatment. And as Matt said, sometimes families go into it and like, okay, yeah, but they don't understand the rigidity and the intensity of treatment. So we explain that to them, and hopefully then they agree because the severity levels.
And so these 7 to 8 day stays, these are at Stanford. Typically, these are really brief. The ones that we've had in clinic have had to be much longer than that. We've had kiddos on the inpatient pediatric unit for over a month. And that's due to acute refusal of food. We've had to put NG tubes in kids, and then send them to residential for about a month. And then they can come back to us after they've had that initial kind of stabilization.
So during phase one, we're obtaining information on how the eating disorder has affected the entire family. We're looking for family functioning, specifically with any conflicts within family members or correlations with the family members. And we're working to reduce and remove parental blame. So the goals, so typically sessions 1 through 10, we're using circular questioning to obtain that history. This is where we start separating the illness from the patient. We're creating a crisis. As providers, we try to limit that anxiety, but with this treatment model, we want to create this anxiety to show the severity and the necessary need for motivation to maintain. And this is where we're starting to charge the parents with weight restoration and assigning the family meal. The goals for bulimia nervosa shifts just a little bit. So in this, we're helping them eat a regular meal. We're including foods that would typically trigger a binge. We're going to explore those feelings in regards to urges that might be coming up during this meal. This is the lovely depiction of a sandy slope. This is how treatment typically will work, right? If we're walking through the sand and we stop, we're going to slide back down to the beginning. We have to keep going and staying motivated. And this is the same thing with treatment. If we gain a little bit of weight and we are like, oh no, everything's going really well. Nope, it kind of comes back and we slide back down to the beginning and symptoms come back in full force.
This curve, it's called the J curve. It's something that we have to educate our families about. The red dotted line kind of symbolizes their expectations. Like, okay, we're coming into treatment, like we're just going straight up from here. Like, we got it. Symptoms are going to improve, the weight's going to climb. But the reality is symptoms are actually getting worse initially because you have to pay attention to it. And that's going to increase tension. And when that tension increases, a lot of times kids will restrict more or purge more. So we have to kind of prepare them like, okay, there's going to be a drop. There might be a drop in weight. You might have some more fights. But once you get it together and you figure out how to control the eating disorder and the kiddo gets it together some, then we're going to have a different trajectory. But preparing them for that little drop is really important.
I've shown some of my clients this chart, and it actually provides a lot of relief for the patient themselves, because when they are wanting the treatment and really trying to do everything we're asking, they get discouraged. They're like, but I just ate that entire pancake and I don't know what else you want from me. They get really distressed because I'm losing weight and we have to explain to them how that is normal. It's a part of this, and we have to have that expectation. So it's helpful for the parents, but it's also equally important for our clients too.
Because thinking about like their metabolism, like if your body's consuming itself, it's breaking it down. Once you start eating more, your metabolism picks back up, and it kind of creates this dip. Even though they're eating probably significantly more than what they were eating before, their body just kicks back in because it's like, oh my gosh, food. And so it's disheartening for some of them. So session 1, we spoke about circular questioning before. This is after the initial intake has been done. We've established, okay, there's some eating disorder present. And we told them, hey, this is a family-based treatment. You've agreed to this. And the family that they've chosen comes in. So whoever you're living with, so a lot of divorced families, they have their own kind of issues to work out with this, but it's still family. So we have to figure out, okay, if you're there, here, whatever. That's a problem-solving session all on its own. But we use circular questioning with the whole family present. And so like, okay, you know, mom, how has this disordered eating affected you? Or how did you see it affect your kiddo? And we asked their sibling, like, oh, is that the same for you? Have you noticed that same thing? And you just keep going around to get a clear view of how it's impacted everybody. We start separating the illness using those externalizing strategies, which we'll talk about on the next slide. And as Kristen had said, we raise the anxiety. Some people, they're already so anxious that they're kind of frozen. So you have to bring them down, but there's sometimes a dismissive parent like, oh no, this isn't that big of a deal. So you have to raise their anxiety and be like, no, your kiddo can die. A lot of times in that first session, I use terminology like that. Like your kiddo could have a heart attack, or your kid's heart could stop. X, Y, or Z. This is a serious thing. You have to act. And that leads us really nicely into making sure that parents know, like, hey, you're in control. You get to decide what, when, how, where this kiddo eats. And that kind of feels yucky at first, especially for the parents, because they're like, often they're like, their kids are excelling, straight A's, doing really well. And they've given them a lot of responsibilities to kind of self-govern. And so taking that back is really challenging, but it's a core piece of treatment. At the end of the first session, we instruct the family to prepare for the family meal. And something along the lines of, I want you to bring a meal that the two of you decide will help save your starving child. And so you kind of leave it open to them and see what they bring. We give them kind of like, okay, we have a microwave, we have a fridge. A lot of families do it picnic style, but you've got to bring it in and we're all going to have a meal together. You don't have to bring anything for me, I'll just be observant. But you all are going to eat here in my office. So strategies for externalization. We use a lot of the disease model, kind of like this is cancer that's consuming your child, it's growing inside and it's taking over. And I use this one a lot, like if your kid got cancer and you knew that this was the only thing that would save them, you would take time off of work, you would take them out of school, you would make sure they got that chemo treatment. And this is really the same process. This is what's going to help save your kiddo. The possession model, like sometimes families like the demonic possession too, like something's inside of your child and it's taking over. And you can see the switch. There's a clear affective shift between when they're kind of just being their sweet little self and then when they're faced with that Subway sandwich and it goes flying across the room. Like there's a different representation there. The intellectual model, a lot of these families really respond to this one. It's a Venn diagram or an eclipse where the anorexic thinking is overlapping the healthy adolescent. It's just fully blocking out what that kiddo wants. For the psychological model or behavioral regression, this kiddo is 13, well, now they're acting like they're 3, so you have to respond in the same way. If your 3-year-old refused to eat, you'd be like, okay, well, we can't go play. We're going to sit here until you finish X, Y, or Z. Some terms to think about that we said before is restriction, restraint, binging, purging, or compensatory behaviors that we'll use interchangeably, distorted or disturbed body image. Restriction, we kind of think of more along the lines of like they've been successful, they've been able to keep from eating, right? Restraint is like, okay, I'm going to delay it, and I'm going to try to not eat. whether or not they're successful. Binging is that eating more than what most people would normally eat within that 2-hour period of time, with that accompanied sense of loss of control, eating until they're uncomfortably full or really fervently. Purging and compensatory behaviors are anything that's designed to get rid of the calories that they consumed. So vomiting, excessive exercising, using laxatives or diuretics. Those are kind of uncommon in adolescents. It's there, but they don't have as much access. They can't just often stroll to Walgreens and pick up diuretics or laxatives. They can, but not as often. And distorted or disturbed body image. There's a study, I think it was done in 2015, and it came out of the Netherlands, where they did a study on unconscious movements in an anorexic patient population. So they had healthy participants and patients with anorexia walk through doorways, and they slowly shrunk the doorways. And so healthy participants turned sideways to get through the doorway when it was about 25% wider than their shoulders. Patients with anorexia turned when it was about 40% wider than their shoulders. So it's not just about vanity. It's not just like, oh, I want to be thin, I want to be pretty. It's really a distortion in how they evaluate themselves, how they see themselves.
Covered a lot of material. Just wanted to open it up for some questions if you guys had any.
You've been quiet. Yes.
You said it goes for months sometimes with your treatment place versus a week.
What is it?
The treatment takes longer, and chestnut hurts sometimes, but it can take upwards of a month.
Mm-hmm. So if we,
Does that include do they have to force feed at times if the individual continues to refuse to eat?
yeah.
So they do like the nasal gastric tubes if there's an acute refusal, because it's like a slow form of suicide, so intervention's required. Part of it's because we don't see it a whole lot here. It's definitely here, we just haven't been treating it. So getting the inpatient protocols in place to make it be speedy has kind of been lacking. And then once they make it to the hospital, sometimes the severity of their illness just takes so much more for them to bounce back. But Stanford has a great program, so they're able to crank them out and be like, okay, 7 to 8 days, you're fine. We're gonna get your electrolytes balanced. We're gonna get you eating again. And then they have an in-house thing where they can start some FBT inpatient and then transfer it to the outpatient clinic.
What does post-treatment look like? So your clients are stable, they've gone through the treatment. What's the likelihood that they'll have a relapse? Or I don't know really anything about this. I'm wondering if it looks more like other addictions where you're always going to struggle with it. It's always something you have to think about, or do people just get better and they're better forever? What does that look like?
I think it's just like addiction. Like some people remain in their recovery and other people don't. I would have to get back to you about the specific prevalence of how well they do, and I think there's a lot of research coming out about what that actually truly looks like and how do different clinics adjust. We haven't talked anything so far about cognitive work, right? This is primarily behavioral treatment, much like exposure therapy. And it seems to be more effective than just individual adolescent focused therapy on the year mark and the 5-year mark. But I'll have to get back to you about the specific numbers. Yeah, effective. So we move on to our phase 1, session 2, which is our family meal, where everybody's there. And our goal is to really assess the family process during eating. So we ask them, like, oh, is this normally how this happens? Are you the one that serves it? Do they serve it? Who prepared this food? Is that the same or different as at home? Often you'll see that these kiddos themselves are cooking for other people. And they'll actually have tons of Pinterest boards about food, and they'll spend tons of time collecting recipes and looking at it. So it's not the food, it's the fear that's really there. So they love to have baked goods for their siblings and have, you know, this new recipe to try out for their mom, but they won't eat it. They'll just give it to everybody else. This allows us an opportunity to assess the family structure and those conflicts and coalitions. So some family members will actually continue to kind of agree with the patient and saying like, oh, like, you're trying to be healthy, like I get it. And that often happens within kind of presentations of vegetarianism or veganism that kind of hides their eating disorder. This family meal allows the family an opportunity to be successful in getting their kiddo to take one more bite of food. And so we kind of, at the initial start, we're like, okay, you know, your family has this meal for you. How much of it do you think you're going to be able to eat? And they give us like, oh, 20%, or, you know, oh, just the meat, or actually it's almost never just the meat. Normally it's like the carrots. And so we use that as kind of a marker of, okay, one more bite. And we use that to encourage the parents and be like, how are you going to get your kiddo to eat? And see how they've been doing it so far. That way we can help them as they continue on. This also gives us an opportunity to reframe the criticism, and some parents will yell and like, how helpful has that been for you? Probably not super, because then the kid starts crying and then they don't eat anything. And sometimes we have this interesting feature that happens where the kiddos eat too easily. They're like, oh yeah, I'll eat it all. Just at you. And that's when we have to use this paradoxical injunction of, you know, I know part of you really wants to be healthy and I want you to be healthy, but if we just fake it, we're not really doing the work. So I really want you to listen to your eating disorder right now. I want you to really fight your parents on eating to help the parents really become successful in that moment, because they're really going to get the full force when they get home.
Just a question about that. When you have clients or the teenagers that do that, where they comply too easily, what does it look like when they go home? What's the reaction usually?
They are powerhouses. They are incredibly manipulative and smart and clever, and they'll just refuse, and the parents are like hopeless. They're like, what do I do? You ate fine in the office, like, and it's just kind of like taking away the power from the parents. And so, little puppet master up here, calling all the shots.
And so they feel more comfortable at home. I know I talk to parents all the time. They're like, well, this is not how my kid is at home. Very well aware of that. So eating disorders are a little bit different from other things, but having them, right, we push them a little bit to get them to react. I know we've definitely had people who got really angry and threw their sandwiches and actually had that meltdown in session, which was an amazing opportunity for us to help coach those parents back to being successful. So it does work. It's really impressive.
It's kind of like you have to prepare the family, like, okay, so the sandwich might get thrown across the room. What do you do? Well, you have another sandwich in the kitchen, and it just magically appears. And like, oh, here it is again. And a lot of families have trouble with that initially, but once they talk to us and the nutritionist, it's really the same message across the board, and you just have to do it for now. Like, food is the medicine, and that's the consistent message that we try to present. You know, it's not magic words from Matt or Kristen or medicine from your pediatrician or your psychiatrist, because at these low weights, the medicines really don't work. But yeah. So the interventions, these are things that we've done since session 1. Every session we weigh the patient and we map it on the chart. So we have a little grid paper. We actually use Epic. So we pull up their growth chart from where they were, where they are, and show the family. It kind of helps us create that crisis if there's been a drop. Like, okay, last week you were here, or you were just released from your PCP last week. This is where you were. Okay, we lost 2 kilograms, which is about 4 pounds, right? So it really helps to motivate them, at least the parents. It's anxiety provoking for the patient. but it's that exposure principle, right? You know, they're eating more normally and they have that drop. They're like, oh my gosh, I've gained 10 pounds. You haven't gained 10 pounds, you've lost 4, right? But they think they've gained 10 pounds. Okay. We discussed eating, any of the issues that they may have. This is about the 10 minutes or so at the beginning of the session with just the patient. We discuss the exercise, like if they've been doing squats in the shower or if they've been throwing up or any of those pieces, and see if they need help kind of bringing it up to their family. None of that is secret. Because they'll try and exploit you. So you kind of have to make sure that that's up front. Nothing about food, eating, weight, shape is going to be a secret. If it's something private outside of that, then we can discuss it and take it case by case. In this treatment, we have to keep focusing and refocusing discussions on eating because they're great distractors, right? But Betsy, she called me a bitch and second period, and it becomes a crisis. Nothing trumps this treatment right now except for acute suicidality, and that's really that really sucks. But this really has to focus on eating. Or, oh, did that affect your next meal? Did that make it harder to eat? You have to keep finding that side door in. Okay? We have to keep supporting the parents because they are at their wits' end. Sometimes they have to decide whether they have to quit their jobs or if they have to take FMLA, if the kid can even safely stay in school. So we have to support them through all of these processes and continue modifying the criticism. Reframe it as the illness. Like, no, their illness did this, the eating disorder did this. I had one family, I had them name it, and they named it a storm. So sometimes it was like a nice little thunderstorm, pleasant, and had a few claps of thunder and it's flashy, but nothing to be worried about. And then other times it was like the hurricane that came in and demolished everything. And so to reframe it, this is the illness, this is totally different than what your kid was a year ago, 2 years ago. And then evaluate and encourage the efforts of siblings. Siblings are so important here because they really know their brother or sister that's going through this. And while mom and dad is putting this pressure, they need a safe outlet. So how can you support your brother or sister in this moment? What can you do? Can you show them a magic trick? Can you go and watch TV with them? Just to kind of help shift some of that thinking away from the disorder and how much food, eating, weight, and shape comes into play. So within bulimia nervosa, those first phases or the first phase is really a little bit different, as Kristen had already said. We start with weighing the patient. Once again, we collect the binge purge report. Did you have anything that happened? And then check if they need help in raising issues, because there's so much shame and guilt about admitting, like, oh, I threw up in the bathroom right after we had those cookies from Dairy Queen or whatever. They really need help raising those issues, as well as any other kind of problems within the family structure. So we give a little bit more support to those kids than what we do kids with anorexia. Continue to focus on eating. The modification of criticism is the same, and externalizing the illness is once again the same. But this process is more collaborative. Like, what do you want to happen here? Right? These kiddos often aren't as rigid, and it's ego-dystonic, so it feels yucky for them. Whereas kiddos with anorexia, it feels good. It's rewarding. A lot of times, like nurses and certain other healthcare providers will be like, "Well, you've got to be hungry. Be hungry." Do you think that motivates them? These kiddos with anorexia, it doesn't motivate them at all. It's just way less powerful. So the family meal is to help the adolescent eat a regular meal. So kiddos with anorexia think they're eating bigger portions. A lot of times kiddos with bulimia think they're eating smaller portions. So their perception's often kind of like reshaping what's a healthy meal look like. And we want to include foods that typically trigger binges. So I think about like pizza for a lot of kiddos. There's something about, those foods for some of these kiddos that just is going to trigger them to feel like they're losing control, or it's a comfort. And then explore the feelings around urges to binge and purge. A lot of times these kiddos have an adverse event that really is triggering this urge to binge. Like, oh, I just feel sad. That guy didn't text me back. Like, I'm just gonna eat something. I'm gonna eat the rest of the Chinese food in the fridge. I'm gonna feel better. And then they start to feel that guilt. Like, oh, I shouldn't have done that. And now I'm gonna get fat, and now I'm never gonna get love. And so exploring those processes that happen and how they evaluate it and how they evaluate their person is really important. So there's a few pieces with binge challenges, which are like the developmental stage of adolescence. Kids with anorexia start a little bit sooner. Kids with bulimia nervosa. There's that shame and guilt and secretiveness, which is common across all eating disorders, or almost all eating disorders, but it's more prevalent in kids with bulimia nervosa. There's more psychiatric comorbidity, so more mood disorders, pieces of OCD, ADHD, and a lot of personality formation pieces that happen there.
So phase 2, our goals start with sessions 11 through 16. At this point, our weight is at a minimum of 90% of the ideal body weight. Typically, we let the medical teams, who are pediatricians, figure out the ideal body weight, but typically it's 100 pounds for the first 5 feet. Any additional inch is another 5 pounds for females, and for males it's 6 pounds.
It starts out at 106, and then for every inch after 5 feet, it's 6 pounds. Yeah, sorry.
You're fine. So patients are, at this point, are eating without significant stress while under the parental supervision. And the parents are really empowered at this point and feel like they're able to manage their adolescents' eating.
And I think important there too is that ideal body weight. That's something that we don't discuss with the patients. We talk about healthy, because when you think about these adolescent girls who are 13, 14, their bodies are naturally going to change. The same for guys. You know, if I look back when I was 13, my weight then would not be healthy for me now. So we shoot for healthy eating habits, your trajectory, where you were originally at, because that's going to change.
So intervention, right? We're continuing to weigh at every session. We're assisting the parents in managing the eating disorder and returning that control back to the adolescent, encouraging sibling support. So as Matt said earlier, trying to build that relationship and just being a social outlet for their sibling. Identifying, separating parents' needs versus the illness. Sometimes, right, we're so focused on them getting better and expect them to be cured or got everything managed, but then the symptoms kind of trickle back in, and acknowledging that. So we're continuing to develop and utilize and enhance positive supports. Sometimes that's collaboration with the school if they're healthy enough to be in school, continuing with FMLA and working with the parents and managing their employment. And sometimes we include friends in building that social network a little bit more here too, because they're stable at this point. Sometimes been isolated.
I think that's really important, because they do pull back, and so it's like reintegration socially and academically, and even into some sports. We hesitate with things that are heavily like shape and body focused, like gymnastics, like long distance running, something that's intrinsically driven or internally driven is kind of, we have hesitancy with that, just because it can be maintained, it can kind of spin up even more. But we want to keep highlighting those differences in what they used to love, what they used to do, versus what anorexia or bulimia has made them do.
So again, with interventions for bulimia, with this, we're going to collect the binge purge, the binge purge symptoms have been reduced, by more than 80%, and they're at a stable weight. They're eating more healthily without significant struggles. Parents are demonstrating that they're empowered and helping manage this illness for their adolescent. And finally to phase 3, so sessions 17 through 20 roughly, we are realigning the relationship to a more developmentally appropriate one without the eating disorder. We're reviewing and problem solving adolescent problems, and we're officially working towards termination. Obviously termination begins in phase 1 and we talk about the process of treatment, but now we're finally getting into planning what that's going to look like. Intervention, so we're reviewing their development and trajectory, model problem solving behaviors. I'm checking in on the parent relationship. This has been a tough process for them. Sometimes, we have to kind of pick and choose sides, but trying to realign together. It's been a very rigid and taxing therapy process. So checking in, making sure they're doing okay. Any brief work on any issues that have come up. Discuss and process the fear of relapse. It's always possible. Creating a plan if relapse does occur. And at this point, the families feel very strong in being able to control that relapse if it were to occur. And then identify any issues that may need to continue after this treatment. And then we would refer them on to someone different, just so then we're maintaining those boundaries in case they have to come back in the future. So then bulimia, neurosis symptoms. So at this point, those symptoms have dissipated. There's still some shape and weight concerns, and then we revise that parent-child relationship in accordance to them being symptom-free.
I think that goes back a little bit to your question earlier. Like a lot of the times these families feel empowered enough, like if they see like, oh, you're cutting down on what you're eating, or oh, you didn't eat dessert, like what's happening here? They feel like okay, well, we'll just go back and you have to eat this, and really help to provide that support and prevent any kind of clinical relapse. So we have a few local resources, not very many. If they're planning on going to W or they are in W community, Recovery House has an eating disorder support group, and then they also have cooking classes that are peer directed, and then they have nutritionists that come and can help people kind of, like, oh, what's really this, and what's that, in terms of the nutrition, calories and things like that. Helena Sadowski works actually mostly with our eating disorder interdisciplinary team. And she's the dietitian that sees the most of the kiddos through adolescent medicine. She has this great example where she asks people, how many calories do you think in a donut, like a regular glazed donut? And they're like, how many do you all think? 300? 300? Any other guess? I heard you said a lot. What's a lot?
I don't know. Several hundred of it, definitely. Say 4.
4? So that's pretty common, right? So like these kiddos are like 500, 600. And for a regular glazed donut, it's about 190. So the perceptions are way off, and when these kiddos think they're getting that, what is it?
I said probably about 30 carbs.
Maybe,
Right.
right?
I'm more concerned about.
So, and they'll count their macros, right? But they often overestimate what's actually in. They have this internal mental calculator that is inaccurate because it blows it up. We talk a lot about kind of phobias. If somebody has a spider phobia and they see it running across the room, like how big do they think it is? They think it's like this big, and really, so their brain is disproportional. So she's been an excellent resource for us. We continue to encourage the family, they're well nourished, their other kids are well nourished. We put it back in their hands, but to give them a safety blanket and to feel comfortable and make sure there's no nutritional deficits. We love having Helene on board, and she's so good at challenging some of those other more direct nutrition or caloric thoughts. Our case manager, Polly Williams, is great. She manages our schedules, and Dr. Bradons and our child and adolescent fellows who work a lot with these kiddos. So some website resources. Feast is a great one. Their chair CEO, her daughter actually went through an eating disorder, and they did the Maudsley method, the family-based treatment, and she's a big advocate. Her daughter had a relapse at the age of 18 or 19, and her eating disorder emerged. And so she took her out of school, and we're like, okay, we're doing FBT again. We got this. And so now she advocates for more resources and make sure that evidence is there for people to have. Maudsley Parents is great to help parents kind of understand what to expect. The National Eating Disorder Association has great resources. They have toolkits for coaches, parents, educators, and providers across the board, like what's the pediatrician's role in these treatments and what to look out for. The Academy for Eating Disorders is great for professionals. Obviously, parents and families can use it too, but it's more of this networking and research forum. The Training Institute is where I got my initial training. I went for 2.5 days to Stanford, well, it was UCLA, but the developer Jim Locke came with Kara Fitzpatrick to train us. We did a day and a half for FBT, and they travel around the country, and they have this faculty that is disseminated across the country that do these trainings. Kristen does she does a lot of research. She's out of Chicago on transitional age youth with FBT. So that's kids who are 18 to 26 or 30, whatever those pieces look like. And so that adaptation would be a little bit different because you might have romantic partners and they might be disenfranchised from their family. And so how do you incorporate that family-based treatment into these eating disorders? So I would check out the Training Institute. And Parents to Parents is also great.
These are just some of the books that we utilize and we encourage some families to read. The Help Your Teenager Beat Eating Disorders. It's actually on its 2nd edition, so this is not correct. I apologize.
It's just blue. It's just blue.
Yeah, the content's the same. It's just different colors. But yeah, so these are some of the tools that we actively use. And the treatment manual actually goes through step by step on how the sessions play out. It gives amazing vignettes on exactly what people will say and what you can do as a therapist or provider to challenge that and work through it. Super helpful resources.
This one's kind of like a screenplay. So there's Bob says this and Purpose says this. And so obviously treatment manuals are there for a reason to create research and help us kind of have this protocol in place, but there's still room to be creative and flexible.
This is our contact information. If you guys think of questions afterwards, feel free to email us, contact with us in any way. We're here to provide that resource. Lovely references. That is it.
Okay, have questions? We have a few minutes left, so if you have questions for Matt or Kristen.
I have a question. You mentioned referrals at the end. Do you not make referrals during the process just to keep the process contained, or if parents are really struggling, do you refer them to maybe a counselor for couples, or what does that look like?
Yeah, so there's a couple of different adaptations, and we should probably include that the next time we present. So primarily there's the family-based, and then there's separated or parent-only FBT. So the patient doesn't even have to be present. We find it helpful because then they can take kind of ownership. If the couple, the parents, are having issues, we would definitely refer them as soon as we noticed it, because they have to be healthy and ready to take this on, because it's very taxing and repetitive, and you have to do it until you get it right. And that's why the faces kind of stretch in or out depending on the effectiveness. A lot of times the depression or comorbid depression, anxiety, OCD features will dissipate when the kiddo gains weight, because it can be secondary to the nutritional pieces, being of a such low weight. But if they remain, we definitely want to manage whatever we can in session. So if they're expressing, you know, anxiety, we're going to give them some tools to kind of help deal with that. But then if it's still present at the end, we try and put them on.
So if I'm understanding correctly, they're not then typically doing individual treatment at the same time that they're doing
Not
this?
normally. Okay. Not normally. They can, and there's this much evidence for that, but a lot of times you'll get splitting. And so part of it is like you have to be consistent between the treatment approaches. So like if somebody's trying to empower the patient to take control, and this is like you're empowering the parents to take control because they're really delusional in a certain way, I think that's going to be a conflict. And so there's going to be a whole bunch of splitting and like, well, this person said this, well, this person said this. With bulimia, we've had a couple of kiddos who have done separate, but we've been really consistent in kind of like how we're addressing that, because it's more for like this individual's specific OCD features versus the eating disorder, and they can overlap, but it's not indicated for a whole lot because of the conflict.
Yeah, we guess about what percentage would you say that these kids actually feel they have a problem? They come into therapy with their family,
That feel like they actually have a problem.
that they need to be there, they have a problem that needs to be worked on.
So with bulimia, more,
Oh, yeah.
significantly more because it's ego-dystonic and it's just like OCD. It takes up so much time, so much energy. The kiddos with anorexia, not very much. They're like, I'm huge. Like, how can you not see this? You're an idiot. I hate you. And so that's why the circular questioning and getting the input from the family is really important. Like, they see it as a problem, and it's causing these medical kind of emergencies at times. So, but the insight is very limited, and that's part of the criteria for anorexia, right? It's not understanding the true significance of the low weight.
I think their developmental stage is really important for that too. I've worked with early transitional youth, so she was on her way to college. She didn't realize that it was a problem until her coaches on her teams were like, you can't participate. And then she was like, oh gosh, no, you're right. And then worked really hard for it. I've also worked with younger adolescents who are like, you guys are crazy, I don't need to be here, and was extremely defiant and rigid in his thinking. So it's very different, I think. So we have to consider that developmental age as well.
All right, thank you guys so much.